Good morning, everybody. Thank you very much for the opportunity to join you for this lecture. I'm very happy to be here and help to talk about abdominal trauma. And I'm lucky to introduce Valerian Dier. He's a young, enthusiastic resident who wants to become an abdominal surgeon. And I hope I can contribute a little bit to your development. I'm happy to hear your presentation.
Today I would like to talk about a very large topic, abdominal trauma. And for time reasons, I want to limit my presentation to the mechanism of injury, signs and symptoms, the most important pathophysiological mechanisms, and also the most frequent solid organ injuries we encounter here at OSZ in our department. The anatomic zones of the abdominal cavity can be divided into the anterior thoracoabdominal, the anterior abdomen, the flank and the back. We can differ between a penetrating abdominal trauma and a blunt abdominal trauma. In case of penetration, stab wounds are the most frequent ones, where liver and the small bowel and diaphragm are frequent organ injuries. Gunshot wounds are not so frequent here in Switzerland. They're more frequent, for example, in the United States of America. They can be divided into anterior, flank, and back. In these cases, we have injury to retroperitoneal structures, or the thoracoabdomen, where injuries to diaphragm might occur. In case of blunt abdominal trauma, the most frequent organ injuries are the spleen, then the liver. In the minority of the cases, we can see injuries to the small bowel. For the mechanism or the pathophysiological mechanism behind it, there's a deceleration, which is differential movement between two fixed objects, which tears, finally, in this case, the renal pedicle. A crushing is a crushing towards the abdominal cavity, where an organ might be crushed against something else, for example, the vertebral column, and makes it to lacerate. External compression is an increasement of intra-abdominal pressure, which damages hollow viscus. There we can have signs also on the body of our patients, for example, the seatbelt sign, which might indicate a blunt abdominal trauma. More frequent or more recent sign might be the seatbelt sign, where the seatbelt external compresses the pancreas against the vertebral column, finally resulting in laceration. And when it comes to assess patients in our trauma room, it's really difficult to memorize the most important parts. And then especially traumatized patients might not be responsive. So in these cases, we need to have a mnemonic to memorize the most important information. And sometimes it's necessary to get different sources, maybe from friends or family or local GPI, to assess the patient correctly. And this mnemonic ample helps us. A is for allergies, M for medications, P for past medical history, L for last meal, and E for events leading to presentation. And especially events is really important to assess because it can help us to understand the mechanism of the injury and what can possibly injure it inside of the abdominal cavity. When we talk about trauma, time is of essence. So we know today that the first hour is referred as a golden hour, and the mortality increases significantly. So we have to be sharp and decisive about our management in the first hour. And it's really hard to make the correct next decision. So what are we going to do? Are we going to do something like a CT scan, angiography, a fast scan, maybe going to send the patient to the ICU, ward him, or maybe even discharge him? Or in the worst case, a surgery? Of course, we call our supervisor. But let's be honest. In order to have to understand the condition of the patient, we need to know his hemodynamic status. And the ATLS program has given us some criteria or parameters to understand whether a patient is stable or unstable. And my question to you, residents, is what are these criteria?
Systolic blood pressure under 90, for example, or the need for massive transfusions?
That's correct. So a systolic blood pressure below 90 on admission with an evidence of skin vasoconstriction tells us a patient might be hemodynamic unstable. An altered level of consciousness and shortness of breath. A systolic blood pressure above 90 but requiring a lot of bolus, transfusions, even vasopressor drugs. And these patients are also referred as transient responders. A shock index above 1 and transfusion requirements of at least 4 to 6 packet red blood cells within 24 hours. And I do understand that this is a very dynamic process, so it's often hard to tell whether a patient is stable or unstable. But for our young residents, it's really important to have some parameters to be sure whether a patient is classified as unstable or stable. When it comes to diagnostics, we have different tools in order to identify certain conditions. And there's one which is the FAST, which is a really quick ultrasonography of the structures, for example, to detect intraperitoneal fluid. And we can do that at bedside and in unstable conditions as well. And what we do is we scan the Morrison pouch, we scan the splenorenal junction, we scan the pouch of Douglas, we scan the pericardium, the pleura, and also diaphragm. In this case, I brought you a picture with a positive FAST of the Morrison pouch, where you can clearly see fluid between the liver and the right kidney. So something like plain radiographs plays a minor role today in the diagnostics of abdominal trauma, but sometimes it can be helpful in case of penetrating trauma, because it can indicate pneumoperitoneum, for example. It can also help us to identify other injuries like rib fractures. There's a picture of a chest X-ray where you can see just free air just below the diaphragm. So CT is considered the gold standard today in diagnostic of abdominal trauma. It has a high sensitivity and a high specificity and can help us to identify anatomical injuries in order things like source of bleeding. And most of the grading systems are today based on these CT scans, so it can also help us in the management process. Here you can see an active extravasation of contrast into the liver, which indicates an active bleeding. So another thing is the diagnostic peritoneal lavage. It's an obsolete tool today, or considered an obsolete tool, where you can detect hemoperitoneum. It's quick at bedside, maybe doable, and might be helpful in mass casualty situations. So what we do is we put in a catheter and inject some fluid, and what we drain afterwards of it might be reddish or even blood, so it can indicate a hemoperitoneum. So again, another question for you fellows. What are indications for emergency laparotomy?
If we see free intra-abdominal air, if we have any penetrating abdominal trauma or maybe evisceration?
That's correct. These are three of more of indications, and it's really important to have a penetrating abdominal trauma treated by surgery in most of the cases, especially if it penetrates into the abdominal cavity. There's a blunt abdominal trauma with signs of hypotension or an active bleeding diagnosed by FAST, a CT scan, or a DPL. Free air, of course, evisceration, a gunshot wound transversing the peritoneum or retroperitoneal structures, gastrointestinal bleeding, or a penetrating object is still in situ. So if we talk about surgery and indication, we also have to talk about the LIFEL triad. It's a vicious circle which comes from heavy bleeding, which results into a hypoperfusion of the tissue and then resulting in an altered level or altered mechanism of ability to increase body temperature. And also it shifts the aerobic glycolysis to the anaerobic glycolysis, which then elevates the level of lactate. And so these two things kind of enhance the coagulopathy, which then enhances bleeding, and the patient might exsanguinate. So how do we prevent this from happening? There's a concept introduced in the early 80s by Stone. It's a damage control surgery concept, and it's all about reducing the time of the surgery. And it's a 3-step plan. The first, we do an abbreviated laparotomy. So we control just the bleeding, we control the contamination, and then we send the patient to the ICU, restore physiological parameters. And the third stage, we're going to do the definitive surgery. It's not clear how long this takes altogether. We consider from step 1 to step 2 also as a second look, referred as a second look. It normally takes 24 to 48 hours, but at a period between the first step and the last step, it remains unclear. So we're not allowed to touch the patient in this period. And this is different reasons. One of these reasons is an pro-inflammatory immune response, which has been activated by the trauma. And normally this would take 1 week to get to a normal level back again. But by having an ATLS, by having a damage control surgery, we kind of extend that period to a certain time. And then the pro-inflammatory response kind of increases the risk for a multi-organ failure. So it's not really wise to do a reconstructive surgery at this time. So at this paper, they consider 3 weeks a safe period, but in clinical cases, there's no evidence where we know for certain what the right timing of reconstructive surgery is. So what are the most frequent solid organ traumas we encounter here at our department? And for liver, it's liver and spleen, of course. We have 180 approximately liver ruptures, where 20% are treated by operation. And in case of spleens, around 160, and almost 50% of these cases are treated by surgery, and just a minority cases in case of kidney. Moore et al. Has introduced a classification system in order to classify basically any solid organ injury, but in cases of the spleen, it's in a grade 1, it's about a laceration or a hematoma, and in a grade 2, it's about an increasement of these depth, for example, 1 to 3 centimeters, 10 to 50% surface area covered of the spleen. And in a grading 3, we have also an intraparenchymal or ruptured subcapsular hematoma, which can be just above 5 centimeters in diameter. And we talk about a grade 4. We also talk about a vascular injury, which can lead to something like a pseudoaneurysm or an arteriovenous fistula, and that can lead to devascularization of the spleen. In a grade 5, we have a shattered spleen and with an active bleeding into the intra-abdominal cavity. So how can we manage these patients? And it used to be that the higher the grade of the injury, the more likely we do the surgery. But new approaches say that it's more about the hemodynamic status of these patients. So even in high-grade injuries, we can have a non-operative management of those. And on the other hand, in low gradings, we can also have surgery as an indication or surgery be indicated. What are our surgical techniques in order to deal with these traumas? So on one hand, we have the splenectomy, and on the other hand, we have a splenic salvage. Splenic salvage can be a partial splenectomy, a splenography, a mental patch, or a combination of these things. And it's all about balancing the risk of a post-splenectomy sepsis, which can be prevented by immunization, versus the risk of a recurrent hemorrhage. And that's a difficult thing to do. So in case of liver trauma, there was a study conducted here at our department where they have experience of 25 years of liver trauma. And this chart tells us there was a shift from operative management towards non-operative management. And what happened actually is there was an implementation of a CT scan at the trauma room, which helped us to understand the extent of an injury. And also the implementation of the damage control surgery helped to increase the survival of these liver trauma patients. To simplify all of it, because the liver trauma classification is just like the spleen trauma classification, we can divide it into a low grade from 1 to 2 and a high grade from 3 to 6. I brought you some typical CT scans in case of liver trauma. On the left picture, you can see a laceration, which is around 2 to 3 centimeters, indicated by a black arrow. And on the right, you can see a subcapsular hematoma around 50% or below 50% of the liver. These are both grade 2 injuries. So to really simplify all of it, there are three clear pathways towards surgery. And one is an unstable condition. There we have to perform surgery. Another one might be we perform a CT scan, and then we have other indicators like an evisceration, free air, or an impalement, which indicates surgery. And the third one for me is the failure of non-operative management. So in stable conditions, or even unstable conditions, we can try non-operative management, for example, angioembolization. If this fails, surgery might be indicated. So what are our techniques to control the bleeding? Because this is the most important part about liver trauma. There's something called liver mobilization, where we cut the triangular ligaments, we cut the coronal ligaments and the falciform ligament in order to get a brighter view of the liver. And then what we can do is we can put laparotomy pads between the liver and the abdominal wall in order to pack it and compress the liver from the outside. We can also simply just put our hands around it and manually compress it. There's a very famous maneuver also about hemostasis control, which is called the Pringle maneuver, where we clamp the hepatoduodenal ligament. And the study I was talking about earlier, they have seen a shift from the early period towards the late period. In the early period, around 50% of the cases suturing was the treatment of choice, and then later on it was only 20%, whereas packing was clearly favorable in the late period. Sometimes higher grade injuries might necessitate something like a hepatic artery ligation, liver resection, bypass and shunting techniques, or in worst case scenarios, a liver transplant. Thank you very much.
Yeah, thank you very much for this short overview, and you can see that in different countries we have different mechanisms and also exposure to this disease. I mean, you have in the US, you really have the trauma surgeon who are really dedicated to that. It comes for volume, or South Africa, while here, even though the number are not so small, we cannot have a team entirely dedicated to trauma surgery. And another thing is to train the people who are in non-academic center and may see few of them. So the last point, I think what's very important is to learn how to do a packing. We receive sometimes patients who have a trauma at another hospital that are transferred to us. And that's very important. The packing is done properly, and it's not a so simple maneuver. If you depend if you packed, we have cases when the liver is completely ischemic, mostly due to the packing and not the bleeding, and then the consequences are very serious. So I think from the teaching to every general surgeon, whatever they are in Switzerland, they need to know how to do a packing of the liver. Maybe the question for our trauma people here, where I think there is some disagreement, and maybe I don't know all the data, is the spleen injury, and you present that, it's relatively frequent. So everybody agree, and when we study that now we have shift from mostly non-operative management versus it was. The reason is very simple. The paper that was published is that now we know better before what we have. With the CT scan, quick CT scan, that was one of the advent here that has completely changed the management. Not that the surgeon changed, but we knew better, and then you can safer do good. That explains everything. Coming back to my point is the role of embolization. I usually don't like this embolization of the spleen. I don't know what is the data. Either we go conservatively, or we can today go by minimal invasive surgery, go and do here some conservation of the spleen. And I don't know what's the data, this is my question, about either using embolization as a bridge or whatever for resection, or whether it come, and often I see a lot of this embolization, and I'm very often question or challenge the indication. Maybe some explanation about that and when it's clearly indicated.
We completely agree that there was quite a large shift in the treatment of spleen injuries. When I was a resident, it was clear there's a spleen rupture, take it out. Matthias and I enjoyed the time. Nowadays, it's nearly no more splenectomies. It's quite rare. At the time of Professor Simmen, we were very, let's say, keen to embolize splenic ruptures with a small, let's say, a shattered spleen or also a hot spot. And we did 24 cases, and we looked at them. We had one issue with the truncus, which was shattered during the procedure. But otherwise, we had no complications. It was mainly proximal embolization, and the patient did quite well. And also in the long-term follow-up, we had quite a lot of patients with a normal splenic appearance. We don't know the function, but we didn't use the immunization scheme that we usually do with the splenectomy patient. But the patients were quite well at the end.
But it doesn't mean you need it. I mean, we know from our side that you can ligate the splenic artery without any very minimal consequence. Sometimes you can have an infarct when you do a distal embolization. I mean, it makes more sense someone to go if there is one pole of the spleen that could. That's the technical aspect. I think that is used. I mean, you need to have clearly on site a vascular radiology that can do that well on a timely manner, because if it's done after it's still bleeding. My question is really the indication. If you do it and patient do well, okay, it's fine. But if you don't do anything, is the patient doing fine too? My assumption is that most of them will do will do too. And again, on our side today, if there is an indication for a better diagnosis or an intervention because embolization, then we can go with laparoscopy or the robot. This is very easy accessible. And then here, there's many techniques. That was too much for this presentation, what you can do to preserve a spleen. But today there are many techniques that we can keep it. And I think it was well presented here that you have to be careful. If there is really, you cannot control, you need to take it out. I mean, today it's really not permitted to lose a patient 3 or 4 days after a spleen injury and just observe and let the patient go. We just know that most of them you don't need, but it still needs to be done. And the splenectomy is also something that belongs to the general surgeon. And a fair number of these cases, they have emergency splenectomy in the past, and it's not here or other places. They end up also with a fistula in the pancreas. The tail of the pancreas is not far from this. There is a bleeding, put some clamp. You just do that, and at the end of the day, the patient may do well or should do well from the bleeding, but you end up with a pretty bad fistula or infection afterward. And that could be also an advantage of any conservative because you usually don't have that. But again, is there any data about embolization versus other approaches?
No, I'm not aware of any, let's say, prospective randomized studies about splenic ruptures, treatment with or without angioembolization. The current literature is rather focusing on thrombosis prophylaxis, when to start, 24 hours, 48 hours, is it safe, yes or no? And also Reboa is quite in currently the trauma literature. When should you do Reboa or not, but not about angioembolization.
I mean, the other thing, maybe comment, I think you say that for liver injury, if you operate, conservative approach is the most frequent for sure, and pediatric particularly, but in all patients. I think here, if you want really to help the patients, the packing, everybody should know how to do a packing. I'm not sure, the Pringle is very nice, you can do it, but it's very difficult in this setting, although it was described initially 100 years ago for trauma. The reality here, when you go a cold somewhere, you do a Pringle, patient has received a lot of fluid, the CVP is very high, you can do your Pringle, you would for sure induce ischemia, in addition, you don't stop the bleeding. So it's good to know, but if someone has no experience in Pringle and will take 20 minutes to do it, or half an hour, most likely the patient will not survive. So my point is that everybody should do packing or know how to do a packing, then need to come the liver surgeon. And if possible, an HPB surgeon who know how to mobilize the liver, know how to go around. Very rarely you need to do a formal hepatectomy, but sometimes is a life-saving procedures. And with a good packing, you can basically control everything except, of course, if you have a disruption of the hepatic vein or something like that in the very dramatic situation. But in most trauma, you can control with a good packing. That means you have several hours here, maybe the day, to transfer the patient to a centers where the patient has a good chance to survive. Because severe hepatic injury is associated with a very high mortality, and some of them could have been prevented by the right approaches.
Beautiful presentation. Thank you very much. I have a question that relates to a different topic, and I think we most agree on the injuries that we have diagnosed either in the CT scan or otherwise. But I think what we encounter more frequently are patients that in whom we have some suspicion of abdominal injury, for example, with some or moderate amount of free fluid but no free air, and at the same time they have orthopedic injuries, they have maybe cranial injuries that need to be taken care of, and so we need to debate whether or not we will have a look into the abdomen or not. And I find that to be challenging. Many instances. Is there any new recommendations as to how to go about these patients? Any other data that has appeared that we should be aware of?
That's a super difficult question. Quite often we don't see just a little bit of, let's say, mesenteric imbibition in the CT scan, maybe a little bit of fluid in the abdomen, but nothing else. Patient is maybe intubated due to orthopedic injuries or the head trauma. Then the question is, do you really proceed with a laparoscopy or laparotomy? It's the peritonitic sign is not, let's say, a good sign in these patients. So I don't have a good recommendation. What I usually like is the exchange with you and talk about, should we do it, yes or no. It's sometimes it's a really tricky question.
Yeah, and so that's the reason why I why I asked it. We've always had the strategy of being more aggressive about these patients and either doing a laparoscopy on day 2 or 3 or do a laparotomy straight up. And I'm sure there's some patients in whom this may not be justified. For example, when they have severe traumatic brain injuries, but I still think honestly we should continue to do so. Because oftentimes missed injuries in the abdomen that are only being recognized a week later when there's peritonitis, when there's other problems, I still feel that's a major source of morbidity in these patients.
I think there's the delay is an issue. If there's a delay of more than 24 hours, I think the patient is in danger, making really troubles. Sometimes they can be extubated within several hours, and then you can clinically judge the abdomen. And in these cases, I would rather wait and see. However, in other patients, it's maybe advisable just to take a look inside.
Well, thank you very much. Great presentation.